Hi, I'm Irene Malaty. I'm Chief of Movement Disorders at the University of Florida. And today I'll be talking with you about how to choose the right candidate for foslevodopa infusion therapy, also known as Vyalev. When I think about this therapy, it's usually someone with fairly advanced Parkinson's disease who's experiencing motor fluctuations. And when we say motor fluctuations, we're talking about the transitioning from relief of symptoms when the medicine is working and wearing off of the medicine, usually prematurely before the next dose, and experiencing return of symptoms, sometimes with peak dose side effects, including dyskinesia, abnormal involuntary movements, sometimes dizziness or orthostatic hypotension at the peak of dose. We generally talk a lot about motor fluctuations, and some people also have non-motor symptom fluctuations with increasing anxiety when their medicine wears off. But this infusion therapy can be useful when somebody is taking multiple doses per day and it's becoming difficult and cumbersome to take medication as frequently as needed to maintain good motor control. So for some people, a good number to think about is 5 doses per day, might be reaching that kind of threshold, but it's not the same number for each person. When these motor fluctuations occur, they should be impacting the person's function, meaning their activities of daily living and their quality of life, and they're looking for more smooth and continuous control of their symptoms. Another time I think about this therapy is when somebody is experiencing interference with their medicine absorption by the food that they eat. So some people in general have poor gastric absorption. Some people have delayed motility that affects the consistency of absorbing their medicine. And some people notice directly that when they eat, it's as if that dose of medicine is negated or it doesn't work as effectively. So this is a means of delivery of levodopa that skips the GI system altogether and is administered subcutaneously. So this can avoid food-drug interactions, and it infuses 24 hours around the clock. So when somebody is experiencing wearing off overnight, which can manifest with unexplained arousals, commonly at the same time each night, or they may have cramping or tremor that disrupts their sleep, and early morning off time or akinesia, this therapy may be a consideration because it's run 24 hours a day. So they continue to receive therapy all night long and all morning long. There is a capacity to adjust the dose so that the dose is lower overnight. There is a base rate, a high rate, and a low rate. And people can also administer an extra dose if they have a sudden off period. Another time we think about this, if somebody is not a candidate for deep brain stimulation surgery, or they're not actually interested. So there are some people who don't want to think about a brain invasive procedure or a procedure that causes permanent changes in their brain, like lesion therapy. The same indications, meaning inability to control the symptoms with optimized medical therapy, apply to deep brain stimulator surgery or even potentially focused ultrasound, but also for patients who might respond to continuous levodopa infusion. It's not a therapy that you expect to deliver relief that levodopa doesn't deliver. It's still working by delivering foslevodopa to be converted into dopamine. So it's still treating dopamine responsive symptoms, but it can do this in a continuous fashion and smooth out the delivery. The other important considerations are that the person either has a very good care partner who can participate in the hygiene and the procedures and steps necessary to safely use the therapy, or they have a cognitive level of functioning and a manual dexterity that will allow them to put the apparatus together, clean the skin, and monitor their symptoms appropriately. In general, this is a therapy that we use when we see the ups and downs in the day cannot be managed with levodopa and adjunctive therapies, and it allows for potentially monotherapy in a lot of individuals. It allows for continuous delivery of medicine, and can help avoid frequent dosing and food-drug interactions. Another subset of individuals that we have seen benefit are people who either are wanting to delay moving on to brain therapies or have even undergone deep brain stimulation and continue to have fluctuations. In these cases, foslevodopa, foscarbidopa can be added and can be an additional component of their treatment. We've also seen individuals who had intestinal infusion of carbidopa levodopa, aka duopa. So those have been delivering levodopa through a PEG-J tube. And we've had some people who respond well to that kind of therapy, but struggle with tube-related complications, specifically falls, dislodging, and obstruction of the tube, and get tired of having to have recurrent procedures to modulate that. So in those individuals, we've had some people transition over to subcutaneous infusion where there's no necessity for a permanently implanted device or a surgically placed device. So these are some of the indications where we've found this therapy to be quite helpful. And it's something to consider in advanced Parkinson's disease.